So in Canada, we're lucky to have had over the last several years availability of ruxolitinib for the treatment of patients with myelofibrosis of a certain intermediate stage 2 or beyond, or symptomatic with intermediate stage 1. And in certain parts of the country, people who had symptomatic splenomegaly with a lower stage would also have been eligible. So this was a great boon to our patients. Now that the drug has been around for more than 5 years, both from clinical trial experience as well as real-world experience, it's clear that it's not a curative therapy, and there are many patients that progress and fewer that are intolerant, and therefore this is an unmet medical need in this population. Clearly, the only curative treatment is a bone marrow transplant, but given the median age of people who have this disease, and the potential toxicity of a transplant, this is not an available option for the majority of patients. So this does represent a real unmet medical need for Canadian patients. The study that was presented here at EHA is an update and a reanalysis of the JAKARTA-2 trial that was originally published in Lancet Oncology about 2 years ago, with a little bit of an unusual form of analysis because the fedratinib was tested in several different contexts. Initially, the trials generated a potential safety concern with what appeared to be Wernicke's encephalopathy. Because of this, the trials were stopped, and therefore accrual, even though it was completed, didn't allow people to go through for full analysis. The Wernicke's encephalopathy issue, I think, has been dealt with a publication that will be forthcoming. Reanalysis of the data that indicates that there probably was other things going on, and true Wernicke's probably did not happen. Furthermore, it seems to have been dose-related and not apparent at the dose that is being carried forward in other trials. Nevertheless, this had the effect of basically truncating the amount of time that patients who could have remained on therapy didn't, because the trial mandated they came off. Nevertheless, the trial, when it was reported, did show a quite exciting response to people who had been previously intolerant or resistant to ruxolitinib, with approximately 50 to 55% of people with a spleen volume response, the standard less than 35% by palpation in terms of the size reduction, or 10% by volume by MRI or by CT scan. But this, because it was done quite early on in the ruxolitinib treatment era, the criteria for entry were a little bit vague, but understandable. If the clinician thought the patient wasn't responding as well as they should have, they could have got on the trial. And there were some people who actually got on the trial with actually a very short exposure to ruxolitinib that was not due to just straight intolerance. So clearly that does complicate how you analyze the trial. So this updated analysis that is quite thorough has done something that I think needs to be done in this day and age, which is to actually be quite explicit about what you call relapse versus refractory. Obviously, for relapse, they had to have had a response, and then it comes back to a response that they've lost. Refractory means they never got the response in the first place, and there are well-defined criteria for that, so that it wasn't quite as vague as it could have been for patients who were enrolled in the trial. It had to do with transfusion dependence or drop in platelet count. That was quite explicitly mandated in terms of this analysis. So this is now an intention to treat analysis of everybody, but then out of this intention to treat analysis, the patients were taken out who, for example, did not complete 2 weeks of ruxolitinib, because that would have been a bit of an unfair comparison, because they didn't have much ruxolitinib and they got another, what we know is an effective JAK inhibitor, and therefore the subset that's analyzed is smaller. And then above and beyond that, they went further to analyze the people who had had the fedratinib for 6 months, or who had been taken off it before 6 months, but for investigator choice, not mandated because the trial said that we had to stop because of the potential safety concerns. So that would have been a true intention to treat, and then a subset of people who actually got the treatment as prescribed, or couldn't based upon the investigator rather than some arbitrary criteria. So that's called the sensitivity cohort, which does show also a good response. So in the intention to treat, now well defined by ruxolitinib intolerant or failures, the success rate for spleen volume reduction is slightly decreased compared to the previous analysis, as I said, because patients have been taken out who didn't have adequate exposure to ruxolitinib, for example. But it's still very good in this tough-to-treat population of approximately 30%. In the sensitivity group, it was a little bit higher, as you might expect, because that's people who were getting the full 6 months of the drug, if possible, up to about 36%. Similarly, the symptom reduction improvement was, again, quite remarkable, not as high as the original publication because you're taking some people out who didn't get adequate exposure, but still quite remarkable in terms of having symptom reduction across the board. I think this clearly is an important finding in a group of patients that is now growing, those who have been exposed to ruxolitinib and either had a brief response or had a prolonged response and have lost it, and who are not eligible for transplant, for which at the moment, other than other clinical trials, there is no viable therapy. Fedratinib looks like it's a very powerful drug in this circumstance, and certainly gave a higher response rate, even with the caveats that I've mentioned on the reanalysis, than I would have anticipated. So I think this is quite exciting and represents a potential treatment option for Canadian patients in the future.